Hello, everyone, and thank you for joining us today. I am Dr. Suzanne Judd, and I'm the director of the Lister Hill Center for Health Policy. I'm so happy to have you all with us for our webinar today. The title of it is Policy Barriers in Transgender Medical Care. For those of you that don't know, we do a semester spotlight each semester where we focus on a particular issue relevant to health policy. And this semester, our series of events is centered around LGBTQ plus health. We have several exciting events coming up this semester, and I'm delighted to have us kick off with Dr. Tangpricha. Make sure you keep your eye out for announcements regarding these events and follow us on social media if you don't already. That said, I do have a few logistics to run through before I introduce our speaker. I would like to point out some of the things on your screen. As a reminder, this webinar is available in listen-only mode. If you have any questions for the speaker, please use the Q&A box at the bottom of your Zoom window. The speaker will answer questions after the presentation. Additionally, we're providing live captioning for this event, which can be enabled through the bottom menu as well. If you have any technical issues at all, don't worry. The webinar is being recorded and will also be posted on our website for future viewing. Now, I'd like to take a moment to introduce Dr. Vintang Preacher. Dr. Tangpricha was actually my mentor through my doctoral training when I was at Emory University. He's a board certified endocrinologist at Emory and Emory Midtown and director of Emory Endocrinology Fellowship Program. His interests include vitamin D, osteoporosis, endocrine disorders and cystic fibrosis, and transgender medicine. Dr. Tangpricha is unique. He actually got his medical degree and then got a PhD. A lot of folks will get an MD, PhD at the same time. But Vin got his MD and decided he wanted to learn some very specific research skills. So he went on and got a PhD after that in the area of vitamin D. And after that, he went to Emory, which is where I met him, and began working with him. And he said, I've got this idea to do some vitamin D research. I got a small pilot grant. Yeah, vitamin D is not very popular to study right now, but let's see what happens. This was 20 years ago, I guess now. Now, all of a sudden, things have really exploded and lots of folks are doing vitamin D research. But at the time, he was really on the cutting edge of getting back into vitamin D research. He's a physician scientist and funded by both the NIH and the Cystic Fibrosis Foundation to study vitamin D, and has published over 200 peer-reviewed articles, reviews, and book chapters. It's with great pleasure that I introduce you to Dr. Tangpricha today. Vin, go ahead and take it away.
Thanks, Suzanne, for having me. I don't know if I've ever told you the story of how I got into transgender medicine, and it actually is related to vitamin D. My mentor at the time, Michael Hollick, who was a big vitamin D expert, that I was a PhD in his lab, and I was looking for something a little bit different at the time and something that no one really knew much about. And at the time, I was a budding endocrinologist. I said, we need to learn more about transgender medicine. And at the time, I was very concerned about bone health because, my background was in vitamin D. So I designed a pilot study looking at the bone health of, people starting on gender affirming hormone therapy. And I guess the rest is history. Started to publish protocols, served on guideline panels, and sort of had this parallel career. I don't know if you saw this career when you were a PhD student with me, but I think it's kind of interesting that now this topic is very exciting and new. And I think vitamin D kind of has gone down a little bit. So that kind of speaks to the cyclic nature of topics in medicine. So again, I'm very happy to be here today. I'm not a policy expert, as you've heard. I'm more of a physician scientist, but I wanted to highlight some policies that impact the care of transgender people. And I've brought up some of these topics at the end, and we're going to have some time for discussion. So I'd love to hear from you at the end. So I've broken up my talk into several different areas. I think it's important to learn about the history of transgender medicine. That's very important to know where we've been and where we are now. I think it's also important to know some of the terminology. The terminology changes every year. It's constantly evolving. So it's probably good to know a little bit about the terminology. I know many of you in the audience are not clinicians, but I think it's good to just touch on how do you make the diagnosis, what is gender dysphoria or transgender, What is the prevalence? I think this is a very important topic. We didn't know much about how many people are transgender. I'd like to share some of that data with you. We'll touch briefly on hormone regimens. I think it's important to know about hormone regimens because it applies to many of the healthcare policies you hear at the end. And then I've highlighted three areas that I think need improvement in our country. First one is legal gender recognition. There's a lot of policies around that, access to hormone therapy, and then touch on some insurance issues. So I like going through the history of the field. As you can see in the y-axis or timeline, not much happened in the field until the last 20 years. In 2010, the word transgender didn't even exist. It was a German physician um, that came up with the word transvestite. Now, transvestite doesn't mean transgender, but roughly, it was a German term, and it was sort of the first description of someone who was born in the wrong gender. And in fact, transgender people have existed for many, many years, but this is the first time it was described in the medical literature. Nothing really happened until the 1950s, until a very public American, uh, Christine Jorgensen, came out as being transgender, and this made the front page news. Um, Sort of something that no one has heard of. And again, years went by. It was until 1966 the first transgender clinic was opened at Johns Hopkins. The first guidelines in the United States were released in 1979. And finally, the first endocrine guidelines in 2009. And things start to pick up over the next 20 years. 2011, the VA provided guidance for physicians taking care of veterans, and the Institute of Medicine released a report on the health of LGBT populations. Um, 2014, the first transgender person appeared on the cover of Time magazine, Laverne Cox, and Medicare released a rule you could not discriminate against someone for being transgender, and they had to be provided care. And I think the biggest tipping point, I think, in the United States was when Caitlyn Jenner came out as being transgender. And I think that really opened up awareness in the field. Just to get you caught up to date with some of the policies that have happened in March 2016, HB2 bill came out saying that you had to use the bathroom of your birth assigned gender. The Pentagon then released ban on transgender troops, and I added the slide today because there's some important news today. And then the Pentagon offered coverage for gender affirming surgery for transgender active military troops. But then the bathroom bill was repealed. So now you can use you had to use you could use the bathroom of your affirmed gender. Trump then blocked transgender military people from serving in the military. And that I've added this slide because today I hear that Biden is now reversing the Trump ban, that now if you're transgender, you can serve in the military. And finally, I'll talk a little bit later about the Affordable Care Act. And during the Trump administration, there was a ban on there was a reversal on discriminating against transgender people, and I'll touch on that a little later. There's a large movement for transgender rights in the United States. I think this is probably the last population that's continuously being discriminated against, and I think you're seeing this all over the country. Transgender people are getting much more involved in politics. This is a sample of many state senators and representatives who have been elected to office in the past few years. And transgender people are getting, advocating for themselves and demanding equal access and equal treatment, especially in healthcare. The transgender field, has been a field of discrimination. Unfortunately, this is a survey of over 6,000 transgender people, and the majority of people lost a job because of a gender bias. More than half were a victim of sexual physical assault. More than half have experienced family rejection, and even 20% have experienced domestic violence. This is a survey in children, and you would think that a school is a safe space for children, but this is a survey of kids who identify as transgender, and more than 80% of kids report being harassed at school. A third are being physically assaulted at school. Even nearly 10% are sexually assaulted at school. And what's most concerning that is 31% of this harassment is done by teachers or staff. And so, schools continue to be a not so safe place for transgender kids. What about in public? How do transgender people fare? This is a survey of transgender people, and they asked, have you ever been harassed or denied equal treatment at a retail store, or been denied or harassed by a police officer? And so up to 25 to 30% reported being harassed or denied equal treatment by a retail store or police officer. What about a medical office? You would think that that's better, right? Not much better. Transgender people report up to a quarter being harassed or denied equal treatment by a doctor's office or hospital, and not much better than a hotel, restaurant, bus, train, or taxi. So, the medical field has to do better as well. And I think a lot of this is probably due to inadequate training and comfort with dealing with transgender populations. This is an interesting question. Did you not see a healthcare provider due to fear of mistreatment in the past year? And you can see it doesn't really matter by race or ethnicity. Nearly 1 out of 4 people don't want to see their doctor because they're going to be mistreated, and we have to do better as the medical field. And we're trying to get out there and educate the medical community on how to care for transgender people. And this discrimination and mistreatment is serious. It leads to, I believe, higher rates of suicide and depression. This is from another survey that 41% of transgender people reported a past suicide attempt. That's compared to 1.6% of the US population, so more than 20-fold higher than the US population. And factors associated with increased risk of suicide attempts are physical and sexual violence and discrimination. So I think that we've got to be much more inclusive of transgender and gender nonconforming people. At this part of the talk, I'd like to just talk about some of the terminology. It's confusing again, and it's important to have some of the basics down. So sex and gender are two terms that are often confused. So sex are the attributes that characterize biologic maleness or femaleness, usually based on internal, external genitalia. We think of sex usually in the binary. There's usually a male or female sex. I don't know if people remember this. This was placed in the Pioneer shuttle that was sent out to space, and in case aliens found the space shuttle, they would tell. It just tells the aliens there's two types of humans, a male and female phenotype, but it doesn't say anything about their gender. Natal sex, or sex assigned at birth, or I think the new term is now sex recorded at birth, is the sex that's given to you when you're born. It's usually based on your anatomy. So when you're born, doctor or midwife looks at you and says, you're a boy or you're a girl. And that's given to you at birth. Now, gender is the attitudes, feelings, and behaviors that a given culture associates with with a person's birth sex. Now, I apologize if these cartoons are offensive. These are stereotypical behaviors and patterns of male and females. But I show this because it helps distinguish sex and gender. So you can see these are from the 1950s, advertisements from the 1950s. And you can see on the left side is a Hardee's advertisement. The male is coming home to greet the child from work, and the woman is in the kitchen. And it's implying that the male's role is to be working, the female's role is supposed to be in the kitchen. The right side is a ad from Schlitz beer saying, "Don't worry, darling, you didn't burn the beer." Someone's recently reversed the roles, and I usually, when live audiences, we get a chuckle, and that's because we hold very tightly what the male role and gender role should be, and that's that. I mean, that's what society puts on us, and for better or for worse, we have certain expectations for what men and women should be doing, and that's, I think, the easiest way to describe gender. It's what society believes men and women should be doing as part of their birth sign sex. So gender identity is one internal's deeply held sense of one's gender. There's no x-ray for this or blood tests. We all have a gender identity, and sometimes it does not match the sex that's assigned to us at birth. And so transgender people are people who express that their gender identity does not match the assigned sex at birth. And this uneasiness, this tension is called gender dysphoria. As I mentioned, every person has a gender identity. Typically in the binary, we have a male or female gender identity, but there's more of appreciation now for people who don't have a gender identity that's compatible with male or female. And that's termed gender nonconforming or gender non-binary. There are people who have a gender identity that doesn't quite fit male or female. And that is a growing segment of the US population as well. Just to complete the terminology section, cisgender are people who express their gender identity matches their sex assigned at birth. And that's the majority of people. Now we've covered the definitions. I hope that that's clear to most people, and there's always confusion. Let's talk about the diagnosis. And for right now, the diagnosis is in the DSM, and it's unfortunate because it implies it's a mental health condition, and that's not true. It's sort of in the DSM, which is the, I don't know, for non-clinician, DSM is a textbook for psychiatrists to diagnose mental health conditions. And unfortunately, due to history, transgender diagnoses were kept in the DSM book. But for now, and there are attempts to move transgender diagnosis out of the DSM into a chapter that's more focused on sexual health. But for now, clinicians use the DSM, and it's pretty straightforward. Someone has gender dysphoria or has a transgender identity if they have a very marked incongruence from their expressed gender, their self-defined gender identity, and their signed gender. And this has to last more than 6 months. Typically people have this for a lifetime, but they put a number of months. So it has to be something that's it can't be just a day that you feel this. You have to have this for much longer than 6 months. And number two, you have to have a strong desire to either rid yourself of one sex characteristics, obtain the sex characteristics of another gender, desire to be another gender, or desire to be treated as another gender. It's a pretty straightforward diagnosis. It does take some time to tease out with each person. But most people have had these feelings ever since they knew what gender identity means, or what it means to be a certain gender, usually in childhood. How many people are transgender? This is a common question. And when I first got in the field, we thought this was rare. We thought this was like 1 out of 100,000 people or 1 out of 1 million people. And actually, this is what the literature did reflect. This is um, some data, old data, looking at the published series. And if you only define being transgender is someone who wants surgery, then it's not that common. Maybe 1 to 10 out of 100,000 people would be classified as transgender. If you use ICD-9 codes, that's the code the doctor uses if you go seek medical attention. Still, the rates are pretty low. But if you go out there and actually ask people, are you transgender? Do you feel that you're more of the opposite gender that's assigned to you? You'll see the rates are much higher than people who have surgery or seek medical attention. And there's many reasons for that, but I think that we're in the past we're really missing a lot of people. We wanted to get to the oops, here we go. Sorry. So we really wanted to know what the true prevalence of transgender was, and I'll summarize briefly. This is a very involved study, and this was a study done with Michael Goodman at Emory School of Public Health. We had access to the Kaiser healthcare database, and we not only identified people with ICD-9 codes, people seeking medical attention, and the physician writing the code for transgender. As you might imagine, you may miss a lot of people because not all physicians will code a visit as transgender. And we also use a strategy using keyword text strings. So if you use a much more robust search strategy for people who identify as transgender, you could see that in the early 2006, not many people would be classified as transgender, but you could see over the almost 10-year period, the number of people who identify as transgender has dramatically increased. This database ends in 2014, but you can see roughly, if you look at these numbers, roughly 50 to 100 out of 100,000 people identify as transgender. All these people are getting different treatments. Some are on hormones, some have had surgery, some may not have had any of those. But at least these data suggest that close to 1 out of 2,000 people in a healthcare system identifies transgender. That's what the next slide here. So, and this is probably, the estimates are probably much higher. This is a study just looking at a healthcare system. This isn't a study going out in the community again. And many people think the estimates could be even higher. These studies don't include children. They don't include people who don't want their gender identity to be disclosed, and don't include people who are not going to healthcare systems. We're going to move a little bit to the treatment, and then we're going to talk about some policy. As I mentioned, there are many different guidelines that have come out, and I'm highlighting the Endocrine Society guidelines. I was fortunate to be on the panel to write these guidelines. They cover diagnosis, hormone treatment, monitoring treatment, screening for health conditions. There's even a section on children. I think these guidelines have been very important for the medical field. Before the Endocrine Society guidelines, there weren't really any guidelines backed by big society. And so I think these have been really helpful for practicing clinicians out there, and really very, very detailed on how to take care of transgender people. And I know this is not a clinical audience, but I think it's important just to understand the different times people might consider hormone therapy. And there are basically 3 times in your life that this is broken up to. So for youth that have not gone through puberty, the field says no hormones. That makes sense. Like before puberty, girls and boys have the same blood levels of hormones. There's no need to go on hormones. And there may be some people. We'll talk a little bit more about this towards the end, but I think there's this is sort of the where the battle line is drawn. But I think it's very clear from the Endocrine Society that before puberty, you can support the child by other things, perhaps a social transition and supportive environment by home and school, but that is just too early to be on hormones. The next cutoff that you should know about are kids that are just entering puberty or in the middle of puberty. This requires a multi-specialty team, and fortunately, we have medications called puberty blockers. I guess that's the lay term, and these blockers sort of delay the onset of puberty, and they're very very therapeutic because puberty is very distressing for transgender children. These blockers are fully reversible. Once the blockers are stopped, puberty can continue. But I think it really buys time. And so some children might not be transgender, but at least they have some time to work with a team to figure that out. Some kids end up being truly transgender and go on sex hormones to transition to the other gender. The third group are adult and children who have already gone through puberty, and that's when uh, people undergo a gender transition or hormonal transition, or the new term is gender affirming hormone therapy. And so I think it's important just to understand, like, I think if you look at the lay community, they're thinking everyone goes on hormones, and that's not true. There's three different areas in life that you have to think about. It's really important to start talk about fertility because if you go on hormone therapy, you will suppress someone's potential to have children in the future. We won't go in the regimens, but I think just briefly, trans men, so people transitioning to a male gender, there's basically shots, gels, and patches. For people transitioning to female, again, for adults, there are medications that lower the testosterone, and then there's pills, patches, and shots. And mentioned for children, there's the puberty blockers that you first start, and then you add the pills or patches. Okay. So let's talk about policy. This is the second part of the talk, and I think there's a major policy issues that we as a country need to help resolve for the transgender community. And I think the first one is legal gender recognition. Now, I didn't really understand this being a cisgender person because I take this for granted. It's like, oh yeah, I'm male, no big deal. But then if you really think about how difficult it is to function in society with having this mismatch on your government ID, it causes a lot of problems. And it's a lot of it's safety. You can't travel in society safely if you don't match, if you don't look like the gender marker on your government ID. It impacts your ability to marry and have children. um, it impacts you having access to healthcare services. If you're male on your government ID and you're transgender female, you might not be able to get mammograms. You might not be able to get services for women's health. And it affects employment. You go. Many patients have told me it's hard for them to find work when there's a mismatch. They present at work and their ID doesn't show the gender and it doesn't match. Sometimes they're turned away. It impacts access to education. It's a very difficult time when kids apply to college and they have to um, they have to, their gender, they may not have changed their gender marker before getting into college. It impacts who they room with, how the teachers address them in school. So there's many different complications that cisgender people just take for granted. So I think legal gender recognition is so important. This is a map of the world. I took this from National Geographic that talk about legality of gender change. The countries that are in dark green or green, gender um, change is possible. So you can see green, or I guess it's a kind of a teal color. These are countries where you can change your gender. Well, that's with a caveat. I'll show you the next slide. It is possible to change your gender in Russia or in certain parts of Asia and Europe. In North America, it's labeled as brown because it's very regional, and I'll talk to you about this later. It's very state dependent on what the rules are. And red is you just can't determine if it's possible or not. Probably not likely. You could see the countries that are it's lit in red. So I mentioned there's in Russia and parts of Europe, you can change your gender, but it comes with a cost. They're forcing you to be sterilized in order to be to have your gender changed, and that is, I think, horrible. So in order to change your gender in Russia or some of these Eastern European countries, they won't approve your gender marker be changed unless you remove all your reproductive organs. And many transgender people don't have the need to do that or desire, or they want to have the ability to have children. And so that is a terrible thing. And I think it's not, I mean, it's against human rights. There are some countries in Europe where you can change your gender without the sterilization requirement. I mentioned the ability to be recognized as your affirmed gender is important for having children in the future. This is a big problem in the United States. Yes, you can have children in a couple in a relationship in the United States, but many parts of the world you cannot be a parent, even by adoption, if you're transgender. I've been working with some colleagues in Thailand, and you can't you can't even adopt someone if you're a transgender woman cannot adopt someone, have children with a partner because their transgender status. And so that's a big problem worldwide. And and it's something that societies are trying to address. Just want to talk a little bit about the United States. As I mentioned, different states have different policies what to do. And this is just a copy of the Georgia license. You can see here it has sex, male. So to change that, and I have many patients coming to ask to change that, it says on the website, in order to update the gender marker of the Georgia ID, the applicant must submit a court order or physician letter certifying the gender change. Okay, I can do that. The letter or court order shall state the person's name, date of birth, date of gender reassignment, operation, other identifying operation. So this is requiring people to have an operation that they may not want or desire. And this is a big problem. And actually I looked up Alabama, what was going on in Alabama. And actually this is very timely. Actually last week, they have the same policy, the same as Georgia. If you go to the Alabama DMV to change your gender marker, they want you to have surgery. And so someone did sue, and I don't know where it is right now, but she doesn't want to have the surgery. That doesn't define, your genitals don't define your gender identity. They don't want to have surgery. So, and I think it's right now, the federal judge ruled that it was unconstitutional. I think that's right. I mean, you can't discriminate against someone who doesn't want to have a surgery they don't desire or need. But unfortunately, as this is every state is different. This is a map of the United States I took from the National Center of Gender Equality. Some of the states in the West, some of the states in the Northeast have policies where you can just simply go into the place where you get your driver's license and tell them it should be male or female, and they change it. You can see in the South, I guess we're F. Yeah, Georgia and Alabama are F. You have to go through all these hoops to change your gender marker. It's very interesting. We mentioned the term gender non-binary or gender non-conforming. Some states are now adding a third gender. I think Oregon, somewhere in the Northeast, is allowing people to have a third gender that doesn't fit male or female. Passports. Again, it's very important to travel safely. You're in a foreign country, and you're I don't want to say part of the world. You might be in a place that's very dangerous, and especially dangerous to be transgender. And if you don't look like or match your gender marker, you can be in trouble. But fortunately, the U.S. Government allows you to change your marker with a doctor's letter. and you don't have to have the surgery, which I think that at least is very reassuring, and at least people can change their gender marker on their passport more easily. I think that's important. You got to be able to do that when you're traveling outside the US. Birth certificate gender change, still the policies are very, very challenging. Again, most of the states say that you need to have a surgical procedure. Here's Alabama. Oh, Alaska, no surgical requirement. That's good. Arizona, surgical procedure. Arkansas, surgical procedure. Interesting. California, there is no surgical requirement. You can just simply have a doctor say that you are now male or female. You don't need someone to have, you don't have to have surgery. Georgia, unfortunately, I find it's very difficult to change your gender marker on your birth certificate. You have to have a surgical procedure. Patients also tell me that they have to put a notice in the local newspaper, which is embarrassing for them to declare that they've changed their gender. I won't spend a lot of time on prisoners. I've learned a lot about prison work. I have colleagues that work in prison, and I didn't realize how important this is. As a developed country, I think how we take care of prisoners really reflects on our society. You can imagine societies that are not as developed as us, the prison situation is terrible. But imagine being a transgender woman, getting arrested, and being forced to be with the males. It's terrifying, and I didn't realize how discriminatory this is until I've been involved in some of these cases. And we have a ways to go, and I think that how we treat our prisoners really reflects on how we are as a country, and then we've got a long way to go. We hear a lot of stories of transgender women who are fully transitioned to everything, being forced to go with the male prisoners. They're abused, they're harassed. It's a very unsafe environment. Healthcare access. I didn't know this, but each state can determine who gets Medicaid. And so some states cover transgender people. All the blue ones here have healthcare coverage for transgender people. And I was wondering why, like places like New York and Boston, like my colleagues there, like, oh yeah, this is not a problem. No problem here. But I didn't know we were red here. So in Georgia, many parts of the South, they exclude people who have a transgender diagnosis from getting healthcare. It's terrible. This is private insurance. 20 states, only 20, um, bans insurers from denying transgender healthcare. The rest of the states, you could deny someone from getting transgender coverage. It's not against their rules. That's very unfortunate. I think I touched upon this in the beginning about the Affordable Care Act. This was put in from the Obama administration. And Section 1557 was a policy put in saying you could not discriminate discriminate against a person based on their race, color, national origin, sex, age, or disability in health programs or activities. And people saw that as protecting um, people, transgender people, and giving them opportunity to have health care. However, under the Trump administration, they interpret this as not covering transgender people. They argued that sex discrimination protections in the Affordable Care Act weren't meant to encompass protections for transgender people. And so this is a policy that's being fought. I have a feeling that this is going to be reversed pretty soon. So because it's very blatantly discriminatory. So be on the lookout for that. Just briefly, I mentioned uh, pubertal suppression. This was a study, just one of many studies Michael Goodman and I wrote, that kids that had access to puberty suppression, delaying their onset of their puberty they don't want, help people decrease the risk of suicide attempts later in life. And you'll see the next few months, there's these continuing state battles. I think the battle lines I mentioned earlier, the battle line is drawn at kids. And so it seems like there's a big group of people out there who don't want kids to have puberty blockers, which makes totally no sense. Puberty blockers buy time, they're safe, they're reversible, and it seems like these are bills being introduced all over the states around the country. I think Alabama was the closest. I think it may have passed. I'm not really sure, but if it does become law, not only can the parents be in trouble, but the doctors could face prison time for giving puberty blockers to kids. And so that's very unfortunate. This almost went through the state here in Georgia, but it was blocked in committee. But you're going to see a lot of these policies coming through constantly, trying to create barriers to hormone access, especially in kids. So in summary, and we have 20 minutes left for discussion, transgender identity is an accepted medical condition. It's not considered choice or disease. We have guidelines. We have definitions for who's transgender. There are over 1 million people in the United States that identify as transgender or a gender non-binary gender identity. Not all these people need hormones. Not all these people need surgery, but a large number of people have a gender identity that doesn't match the sex that they were assigned at birth. There are many guidelines in the medical community for safe use of hormone therapy. There are many policies. I talked about many policies that vary by locale in regards to legal gender recognition. I think this is something we need work on. And healthcare access is probably the major issue for the transgender population. And we need to do better in terms of coverage, better in terms of discrimination, access. So there's, I think I'm glad I'm here to speak today because I think we need a lot of help. We can do, I think the medical side is pretty well mature, but we really need better healthcare policies so that this group doesn't suffer the consequences of not having access. And that's the end of my talk. And I thank everyone for their attention. Happy to take questions at this time.
Thank you so much, Vin. That was really, really fascinating. I actually do remember, I think it was Friday Clinic that you did transgender medicine while I was there. And it was always something that was different than the vitamin D clinic. And this was 20 years ago, and talking to you about it, could you tell the group a little bit more about how you got into it? Because I can remember some of those early conversations and you would say, there are no guidelines on this. I'm just calling colleagues and asking what to do next. So could you tell us a little bit more about when you first got into it?
Well, it went back really far. The first time I can even go back to high school. I remember in high school, I was on a family trip to Thailand, and my parents had brought me to a variety show, and one of the acts had transgender people, and I was like, oh my, I didn't know these people existed. I was a little scared at first. I was a kid in high school. But I kept that in the back of my mind, said, oh, wow, there are people that are out there that are transgender. That's very interesting. And in med school, I met, during an endocrine rotation, met some more transgender people. And said, wow, this is an area that needs more attention because it's not written anywhere. There wasn't anything written on this topic. And so finally, when I became an intern, I met a transgender person on the medical wards. And I said, can you come to my clinic? I want to learn. I want to give you the best care, and I want to learn from you. And at that time is when I started to go to the different libraries. This is before PubMed. You had to go Xerox things. And so I had to go Xerox articles and learn about it. And I just wrote a little review on what I saw in the literature, which was very tiny. And that started sort of people thinking about it. And then I was asked to join a group to write guidelines. And so we wrote guidelines, and the guidelines have been revised, and the field continues to evolve. I show the timeline for transgender medicine. The field is so young. It's not like other conditions. It's really still in its infancy. And so there's still a lot of work to be done. But I think it's good to hear that people are getting more and more interested. I know that UAB has now started a large transgender clinic. I've been in touch with some of the folks there, and we're thinking about doing some studies together. So every state has a sizable population of people, as I showed you, that need care. So that's the short version of how I got involved. I stayed involved because I
Yeah.
feel like there's a lot of work to be done here.
Yeah, absolutely. And it's a good plug. I want to let folks know on the webinar before we go to some of the questions that the School of Public Health is actively recruiting right now for a chair of LGBTQ plus health. I think that one of the points you highlighted, that study that you did with Mike Goodman, was so, it really demonstrates how important it is to have data so that we don't assume things just because we think that we know what the data are. We do a better job to collect the data we need so we can understand the prevalence and health conditions, risk factors in people that are transgenders. They might have different risk factors when we look at breast cancer or certain outcomes. So it's really important to collect the data.
I totally agree. We don't know a lot, which is a shame. We don't know if these hormone regimens are safe long term. So far, we have short term data, but like going to 20 years out, 30 years out, we don't really know.
Yeah, absolutely. So you've got one question here from Emily Johnson. Hi, Dr. Tangpricha. I know a lot of issues with transgender healthcare stem from policy, but what can we do in the healthcare community to better serve transgender patients despite the policy issues?
Well, I think I hear from most folks that's important for transgender people is just to have a very gender inclusive environment. I remember when I first started, it wasn't hard to get people to see me. I was just nice and allow, and alleviated people's concern that I wasn't going to discriminate against them, and I just got people word of mouth. But I think now, people, that means a lot to people that are transgender. They want to know that the environment is safe, that you're very inclusive of all different gender identities, and that starts from the beginning when they walk in the door. That with their intake forms, is it only have male or female, and it's also asking their preferred pronouns. I know that people might think it's silly, but saying that, introducing yourself, I am Vintang Preacher, I use he him pronouns, what are the pronouns you use, something so simple. Asking what their preferred name is. I think that's so embarrassing when they go, John Smith, John, and someone stands up and they don't look like a male. And so there's a lot of simple things that the healthcare environment can do, and we're working on it. I think we're not there yet. We're not perfect. There are mistakes made in the medical community, but I think we've tried to do a really good job in our clinics, training our staff, our front desk people, not to assume people's gender identity, asking, not assume. I think that's the key: asking, not assuming. Like you said, we can't assume.
Yeah, absolutely. Absolutely. Then we've got a question here about how you can best identify an endocrinologist that will prescribe hormone replacement therapy for trans patients. Can all endocrinologists do this? Can they deny a patient if they want?
That's a great question. You know, the training of, I mean, this training hasn't been in the medical education community until recently, and I don't think endocrinologists. I think you had to graduate past, like, after maybe 2015 to feel comfortable they know how to take care of transgender people. Because when I was in training, like I said, I had to look it up myself, and I wrote the paper. And so there wasn't any of this in training. So I would say not every endocrinologist is comfortable, and I think it's probably best to ask first, call the office. There's no reason why they can't do it. I mean, it's in the purview of an endocrinologist. But in terms of refusing, I guess I don't know if they can refuse, but they should help you find someone that can take care of it. You probably want to see someone who's more expert in doing hormone therapy than just going to any general endocrinologist.
So, as you know, I do a lot of work around rural and racial disparities in health. And we've got a question here talking about one of the challenges we see sometimes when we do racial disparities research too, and that the public will take the findings from our research and actually use them against the very community that we're trying to help explore where the disparities exist so that we can, reallocate healthcare and better serve various communities. Do you have any ways that you try to combat that when you publish research to try to make sure that the research you do is not used to harm the community being studied?
I think a lot of it is sort of trying to educate the community what it is you're trying to accomplish. I know that Mike Goodman and I and colleagues got some flack a few years back when we reported the cardiovascular outcomes showing that there was increased risk of stroke and blood clots in transgender women, and there was a concern that we were publishing this because we didn't want transgender women to get hormone therapy. And like he's like, no, this isn't the reason why. We're trying to raise this as a concern so that transgender women don't have these problems. I think it's just going to take some time. I think the transgender community is mistrustful of research, and it's going to take education. I would highly recommend involving transgender populations in research at the very beginning in the design of the research project, so you can hear their voices and hear some of their concerns. I think the partnership is the way to go. But yeah, you raise that's an important thing, I think, for this research to move forward.
Yeah, absolutely. And just so folks know, in the chat, there's a link to a New York Times article talking about how the Supreme Court has upheld that discrimination in the Civil Rights Act does apply to gender identity. Yes. And so the question to you was, might that change the fate of some of the policies from the Trump administration now that the Supreme Court has upheld that gender identity is protected?
I think so. I mean, I'm not a political expert. I know some of the things that Trump put forth weren't really like put into law. They were just sort of statements that weren't really no one could really act on. But that Supreme Court hearing, that the decision in the summer, I think should reverse any potential discrimination. But again, there's some state issues too. So I'm not an expert in state law and government law, but at least from the federal level, that should hold.
Yeah. And then, we fill out these terrible NIH forms that for study enrollment. There's a question, how do we correct what's on the forms when we aren't given very many options?
I know. Josh Safer, I don't know if you got to meet Josh. Josh Safer and I wrote a little commentary, I think in October, at one of our endocrine journals, saying we need to update this because like it's not good science, because they're probably transgender people in these cells, and it's and we need to separate those people out too. So I mean, I think also there's a problem with the electronic medical record. You're only given one choice. So I think there are people looking at this. They do want to create different gender categories. I think we have to, if we really want to get down to to the bottom of this.
Yeah, absolutely. We've got a question here around children. You talked a lot about the battle lines that it sounds like are at the heart of the transgender movement in children. How do you diagnose children as transgender, and can this influence the policies around transgender medicine in children?
Well, we know that from a lot of the studies in Europe, your gender identity is pretty fixed after age 14. Certainly after 16, like that is pretty solid. Whatever gender your identity is at that point is pretty solid. So I think the short answer, it takes a lot of time for children. I mean, some children, it's very clear. Like they've been doing this since they could walk. For those kids, probably at a age between 14 and 16, Some hormonal intervention could be introduced. Um, I think for sure puberty blockers, which I don't understand myself, puberty blockers is the right thing to do for people. Just block it, buy some time, don't have the child be forced in any situation, and allow the family to work out the issues. But to take that away doesn't really make much sense to me. Um, but after 16, most people can articulate their gender identity very easily. But I think it's really that's the battle line. Like, okay, well, how do you really know? But I think it's really time and working with the families and deciding what's best for the family. And I think the people on the opposite side of these state laws are that this should be a doctor and patient decision, not a state decision. The state shouldn't come in and say, hey, we're not letting you do anything. Wait till you're an adult. That is not the right thing, because going through the wrong puberty is very traumatizing and harder to reverse later.
Yeah.
So,
Yeah. Well, we're getting close to the top of the hour. I was wondering if you might answer a question related to when you are caring for a patient. When you see a transgender patient and they tell you they've been denied healthcare, can you give an example of what that might look like? What are they reporting? You know, is it doctors just flat out refusing them, or is it something else?
well, I think the most common is they're being denied some of the hormones. So like I'll prescribe a hormone, and it's such a battle to say no, they need this because of XYZ, and all the paperwork has to go with that. So they're being denied hormone treatment. They're being denied some surgeries. um, I don't think they're necessarily being turned away from seeing a physician. I haven't heard of that. They might not have access to one. There may be a hospital that just doesn't have anyone with expertise, and just, I guess that could be a form of denial, because most endocrinologists should be able to take care of this. That's sort of denial based on just lack of knowledge. But I think primarily it's the medical services, the hormones, it's the surgery that people are being denied.
Well, I really want to thank you and make sure that you've got time probably to race off to your next Zoom call here. But we really enjoyed having you on today. You may have some folks that want to follow up with you individually. Sounds like you may be doing more work with UAB, which is great.
I'm always doing work with UAB.
That's fantastic. That's fantastic. So hopefully we can continue this conversation. And it sounds like you've given us our charge as well in terms of the health policy areas where we need to do a little bit more work.
I'd love to work with some people, and there's an area I don't know much about, but if I can help, it'd be amazing.
That would be fantastic. Thank you again for coming, and thank you to all of our attendees for joining today. It's been a wonderful webinar, and we really look forward to working with you again.
Great, thanks.
Bye.